I'm Dr. Larry Santora, and this is Health Matters. Welcome to Health Matters. Later on today's show, Dr. Herbert Rettinger will tell us what you need to know about diabetes right now. Also, my wife, guest host Rena Santora, joins the show and we'll discuss whether or not eating organic foods is really worth the extra cost. But right now, our first question today is, are you getting a good night's sleep? We're all too familiar with snoring, and a little bit goes a very long way. Dr. Edward Lee is a specialist at St. Joseph Hospital Sleep Disorders Clinic in Orange, and he's here to tell about the latest treatments for snoring. Thanks for coming, Ed.
Thanks for having me.
So, Ed, snoring is a problem. Everybody talks about it. It's at every dinner conversation. What is snoring? What causes it? And what can we do about it?
Well, as you know, snoring is very common. Some reports report it to be as high as 30% for people around the age of 30. It rises to about 40% in midlife. Even for children, you can see it in about 5% of the population. Snoring is basically when your muscles relax in your throat and your mouth, and air passes by and they rattle around. As we go into sleep and we descend into our deeper stages of sleep, our body gets progressively relaxed or paralyzed. And some people feel that that's a defense mechanism, so we don't really act out our dreams in our REM or our dreaming sleep. The only muscles that should be moving in that stage are the eye muscles, the heart, and the breathing muscles. But that also means that the muscles of the soft palate, or that little punching bag that hangs down in the back of your throat, your tongue and your jaw, will flop backwards. And when air passes by and rattles around, that's what snoring is.
So the treatments, and the fatter you get, the more you get fat in the back of your throat too, right?
That's true.
And is that why fatter people have more snoring problems?
That's one of the reasons.
Yeah.
I mean, we definitely see that there's much more redundant tissue in the throat area as people tend to get heavier. But you also increase the amount of work that the body needs to do to be able to move air, and that takes away from keeping tone in the throat and the mouth, and contributes to that snoring.
Well, that's interesting. Are there exercises that you can do to build up the tone back here, so you have, when you flop backwards, you have less of that laxity in the muscles?
Unfortunately, to the best of my knowledge, there's not. Unfortunately, as we get older, we do tend to lose some of our lean muscle mass, and this is another thing that contributes to the laxity that occurs. In fact, as we see people get older, they tend to snore even more.
And so what are the, we come to you, the wife's complaining. I know it affects the whole family. The wife can't sleep or the kids can't sleep, and everybody's grouchy because they haven't slept. So it can be a real family problem and as well as a health problem. So if they come to you, what is the first thing that you do with them? How do you evaluate this whole process?
Well, a very important part of looking at snoring is to get a good history. And the main reason is that you really want to discriminate between snoring and something called sleep apnea. Sleep apnea is an episode where when that tissue becomes really floppy, it actually falls back enough to block the breathing tube, and that can lead to long-term health consequences. We know that people who have sleep apnea have higher rates of hypertension or high blood pressure, higher rates of pulmonary hypertension or high blood pressure in the lung system, higher rates of heart attacks, higher rates of strokes, and higher rates of cardiac arrhythmias or abnormal heartbeats.
So is there a degree of sleep apnea that's safe? I mean, when you evaluate that, can you say, well, you have sleep apnea, but it's okay?
Yeah, the only way to really discriminate between snoring and sleep apnea is to get something called a sleep study. About 20 to 40% of people who have snoring actually also have sleep apnea. And the sleep study can actually not only determine whether you have just snoring, whether you have sleep apnea, but will also tell us the degrees of sleep apnea that you have. There is a scale that we use, and in fact, in that scale, we also consider something called upper airway resistance syndrome, where you have snoring that doesn't actually stop breathing but disrupts your sleep, so that even someone who sleeps all night and does not have sleep apnea may continue to be tired just from disruptions caused by the snoring. And the sleep test actually will help you figure out where you are on that scale and how severe your sleep apnea is.
And upper airway, you mean up here?
Oh yes, I'm sorry. So we're really talking about the airway going from the nose, mouth, and the top part of the throat down into the windpipe.
So somebody who snores, when should they really seek professional advice? I mean, when should they come and see a doctor? And Should they see you or a family doctor or a lung specialist? Who do they see when they first want to get evaluated?
Well, I think any of those options are actually appropriate. Some of the most common people who come to see us are actually sent in by their spouses when they have very loud and disruptive snoring. Certainly people who sleep what they consider a good night's sleep but still don't feel rested should also come in. People who have frequent arousals in the middle of the night also should be considered candidates for sleep apnea evaluation. People who say, oh, I have to get up every night to use the restroom several times a night, sometimes that's actually a sign of sleep apnea. So these are people who really should consider seeing their doctor and getting the next appropriate steps done.
So this sounds like every cardiologist that I know. Nobody can't sleep, they're always tired and getting up all night.
That's like every doctor.
That's right, every doctor, right.
The big problem is we do know that people who have sleep apnea, they have about a 3 times higher rate of having cardiac problems, including heart attacks, and about a 4-time higher rate of having strokes. So it does impact the health quite profoundly.
Yeah, it's a big problem. So what are the, you have a few devices there, what are the surgical treatments for, say, snoring?
Well, typically...
Or medical treatments also?
Yeah, typically when we're thinking about snoring, there's several things that can be done. Non-surgical ways of treating it, lifestyle is a very important thing. People who drink close to going to bed tend to have more problems with snoring. People who are overweight tend to have more problems with snoring. So we try to encourage people to lose weight. We know that people who sleep on their back tend to snore more because the tissue tends to collapse backwards. So even positional changes can make a big difference, learning to sleep on your side or sleeping prone or on your stomach. You can get a special jaw device called the mandibular repositioning device, and this is an appliance that you put in your mouth that helps to pull your jaw and tongue a bit forward to help prevent this tissue from collapsing in the back. And the ultimate way to cure sleep apnea non-surgically is to use a device like a CPAP. I brought a few masks here. This is a device that will give some positive pressure into the nose or the mouth to keep the airway open.
So what does CPAP stand for?
I'm sorry, that stands for Continuous Positive Airway Pressure. And that's just a device that's providing air that will act as a barrier to prevent the tissue from collapsing.
So it's pushing air in all the time so this thing doesn't have time to collapse in the back?
Exactly. And then in terms of surgical things, if you just have snoring, a lot of our treatments for snoring are designed to help open the airway. So that can involve straightening the bone in the nose, shrinking that tissue that hangs in the back of the throat, removing the tonsils and adenoids in children. As we go into sleep apnea, then we have to do more aggressive surgical treatments, including sometimes moving the tongue forward, either using some repositioning devices or having the jaw move forward. Sometimes we also will do some things to try to open up the hyoid bone or a bone in your throat. We'll try and pull that forward as well. So there's a variety of surgical techniques we'll use to try and open that airway.
So what are these two devices here that you have?
We have a couple things here that are primarily used for snoring. These are office procedure devices. This first one's called a somnoplasty, and what it does is it delivers a small amount of energy into the soft palate. Although it will cause a little bit of a sore throat, people generally tolerate it very well without requiring general anesthesia.
It's heat? Is that what you mean?
Yeah, it'll create a little bit of heat, which will cause a little bit of scarring and make that tissue get a little bit smaller. We have a mechanical device here called a pillar implant system, and actually will deliver a small synthetic device into the soft palate to provide some rigidity to that palate.
I mean, across the top, it goes that way, across the palate, across the top?
It actually goes front to back. Where the palate is, it will go in kind of like a scaffolding to try to prevent that tissue from collapsing.
Really? Does that work very frequently?
Yeah, both devices can be very effective. The pillar device is actually FDA approved not only for snoring but also for sleep apnea, although it's really used in select cases.
And you do that in the office, both of these?
Both of these procedures can be done in the office without general anesthesia or having to be put to sleep.
What's the recovery time for most of these? I mean, can you go back to work in a few days? Or,
yeah, most people can go back to work. I mean, there is some discomfort associated with the procedures, but it's generally well tolerated with mild pain medication.
So before you get to that, will you try some so you mentioned diet, maybe exercise and avoiding drugs, sedatives. Is there other things that you can use like decongestants or anything like that to help clear this up?
Certainly people who have nasal congestion tend to have more problems with snoring. So using things to help stop allergies, things like antihistamines, decongestants, and nasal sprays can be helpful. Although particularly on the decongestant side, we worry because that can sometimes make people not be able to sleep. It has a little bit of a stimulating effect.
Getting jittery.
Yeah.
So mainly the best things to try would be like a nasal steroid or something like that?
Yeah, even a mechanical device like a breathe right strip, which you might see on some athletes when they're playing games, sometimes can be helpful for people who have nasal congestion, for a particular type of nasal congestion.
And so when they come to your office, you would determine whether it's in the nose or in the back of the throat and maybe try conservative treatments first.
Exactly. What you want to try to do is identify the level of obstruction. The problem with snoring and sleep apnea is it does tend to be multi-level, and oftentimes just one modality will not be sufficient to correct the problem.
Well, that's great. Well, we're running out of time, and so to summarize it, there's things snoring has to be evaluated, right? And you can try conservative treatment, see a guy like you, or your colleagues, or even a family doctor first, or a lung doctor, and then you'll decide whether medicine works, or surgeries, or and CPAP.
Exactly, and whether a sleep study is appropriate in that particular case.
It's a big problem. I mean, everybody talks about snoring, and you know, I put patients to sleep for their angiograms. I hope I don't snore. Everybody says that right away. I hope I don't snore. So everybody's conscious of it. Everybody's embarrassed about it, and it really is a health problem. Thanks so much for coming. It was a great discussion. I think we learned a lot. I certainly did, and I really appreciate it.
Thank you for having me.
Thanks very much. We'll be right back.
Fact or fiction? Worry and stress can turn your hair gray.
Fiction. Mothers really can't blame their gray hairs on the antics of their kids. Melanocytes, which are the pigment-producing cells in the hair, are genetically programmed to stop producing hair color at a certain age, regardless of how much stress you have in your life. In the United States, more than 24 million people have diabetes. That's nearly 8% of the population. Joining us today is Dr. Herb Rettinger. He's the president of the Endocrinology Medical Group of Orange County, and he's here to discuss what you need to know about diabetes. Herb, thanks for coming.
Oh, my pleasure, Larry.
I mean, you've been involved with this your whole life. You're the vice president of the California Association of Endocrinologists, and I know you're one of the most leading endocrinologists around, and we've worked together for many, many years. As a cardiologist, I see the ramifications of this disease on my patients. Why don't you explain to us what diabetes is and how you make the diagnosis now?
Sure. And you're right, Larry. Diabetic patients are very, very prone to cardiovascular disease. As a matter of fact, that's our primary issue in making the diagnosis early and treating our patients to avoid a visit to your very fine office. We define diabetes as elevated blood sugar in the fasting state above 126, and after eating, or 2 hours after eating, of greater than about 180. And you mentioned 23 million diabetics in the United States. That's growing by 3,500 patients a day in the United States.
That's amazing.
And we have what we call pre-diabetic population, which in the United States is about 57 million. And those are patients that have blood sugar levels fasting between 100 and 126, which puts them in the mildly abnormal range, or after eating greater than 140 but less than 200. So it's a big population, all right.
So if somebody wants to be screened and they say, I mean, they want to know, do they have diabetes? What's the best way to approach it? Should they get one of these glucose tolerance tests? Should they, what is the best test that they should get?
Well, the first thing is a suspicion by the healthcare provider or the physician if they're going to see their primary care physician. Patients that have diabetes in their family are at high risk. Any non-Caucasian ethnic background puts you at a higher risk. Abdominal obesity puts you at a higher risk. Patients that have frequent infections probably should be checked. And women that have had large babies or had gestational diabetes or elevated blood sugars during pregnancy should be checked. And sometimes it's just as simple as a random blood sugar in the doctor's office or a more formalized specialty test using a glucose drink in the morning and having 1 or 2 quick blood tests done.
The glucose tolerance test, is that what
Well,
you're
it's an
referring to?
abbreviated, much kinder glucose.
shorter one, yeah.
Much kinder.
Yeah. So There's other tests that you do to measure diabetes, like the hemoglobin A1C. Can you explain what that is exactly?
Oh, glycohemoglobin or hemoglobin A1C is a test that I think every diabetic patient or family member has heard about. And essentially, it's a summary test. And it tells us over an 8 to 12-week period what the blood sugar averages have been. Now, we don't use it to make a diagnosis of diabetes because it's kind of like a grade point average in college. So you can have a B average, and that means 4 A's and a D. So it just tells us kind of where you've been, but not when and what day your levels were high or low.
So this is a single blood test that measures glucose control or blood sugar control for a month or so?
Actually, for 2 to 3 months.
2 to 3 months. So a patient who doesn't have diabetes shouldn't go in and demand this test from their physician?
No, it's helpful to have a negative test, but there's a broad range of low. If someone usually is at a level of 4.5 and they come in at 5.8, that's still normal per lab, but it's higher than they used to be. So a single test may not be as useful as possibly getting a blood sugar.
Now, in my career, diabetes, the treatment has just seemed to expanded dramatically. There's so many tools, so many drugs, so many different things. So if somebody's diagnosed with diabetes, are they put on medications right away, or does it depend on their blood sugar? How do you?
Well,
I know it's a complex question, but
yeah, we get asked that question all the time. Usually, if it's mild, nothing more than some behavior modification is needed. We call it TLC, for therapeutic lifestyle changes. So we have patients that come in and say, you know, I only eat 1 meal a day, and that's like the freeways being empty the whole day, and then at rush hour, every car in LA tries to get on. So we try to change that to more frequent, smaller meals. And if we can get patients to exercise and lose a little of the abdominal fat, sometimes that's all that's necessary, and we don't need to write a prescription at all.
I see you have some interesting tools here, and I know it's getting complicated. Why don't you tell us what these nice-looking devices are? What's this one here?
This one here is just a very simple and representative glucose monitor. There are about 6 or 8 of them on the market, and they're relatively inexpensive. It allows our patients to check their blood sugar at home, something we didn't have 10 or 15 years ago, and has just advanced our diabetes control and management dramatically.
And it still requires a finger stick, though.
But it's a painless finger stick. And we use the side of the finger, Larry, where there are very few sensory nerves, but a lot of blood. And we require the teeniest drop of blood. So it really fits into everybody's lifestyle. It takes 5 seconds to get the result. Simple, easy, quick, and painless.
And tighter blood sugar control, is that correlated with less complications from the diabetes?
Oh, absolutely. Matter of fact, if we can keep the blood sugars as close to normal as possible, our major goal, you know, is to keep cardiologists wondering where their patients are.
Well, don't be too good at this.
No, well, we're trying. We're trying.
And what is the next device you have there?
Well, you know, frequently patients do have to go on insulin. We have some wonderful, wonderful oral agents now. We understand the physiology of diabetes so much better. But there are times when the type 2 diabetic, and type 2 diabetics make up 90% of our diabetic population. And those are the patients, Larry, that still make some insulin but have some degree of resistance to the insulin. But somewhere along the line, it's frequent that patients need to go on insulin, and we now have insulin pens that allow you to just turn a handle and put in the right amount of insulin. And I want to show you something, Larry, because it's amazing. There is the needle. I'm going to hold that up if you can see it. This is a painless way of giving insulin. I'll leave that here in case the camera wants to get closer to it. And these have made our lives so much easier.
I imagine that's dramatically improved compared to drawing it up and measuring it.
So much simpler.
That's great. So and the next device is?
This device is a representative of one of the many wonderful insulin pumps that we have available for patients that require insulin. And what it does is it gives a small amount of insulin almost on a minute-to-minute basis. and you can program this and tell it when to give bolus amounts of insulin to cover meals or to help bring down blood sugars.
Bolus meaning another little extra injection because the blood sugar goes up after a meal.
That's exactly right. And this has enabled patients to have much more freedom. Most of them are waterproof. You can wear them in the shower, you wear them at night sleeping. And it has just allowed our patients tremendous freedom and ability to control their diabetes and pretty much prevent our complications as much as we can.
So smaller than a pager almost, really.
Oh, it's wonderful. They're wonderful and easily usable. Anyone that can use a computer or a little iPhone will have no trouble using an insulin pump.
That's great. And the last funny-looking device, what is
Oh,
that?
yeah, this last device here I brought in, this is something new, Larry. It is a continuous glucose monitor. These are made by a bunch of different companies, and this allows us to measure blood sugar every 5 minutes and transmit the result either to a pump or to a monitor that the patient carries. And there are actually now a few companies that are manufacturing these, and they give us trends. They actually show us that the sugar levels are going up, sugar levels are dropping, and
That's fantastic.
the monitor screens have alarms put in them that you can set yourself. So if the sugar levels are dropping too quickly, an alarm goes off. Sugar levels go up too quickly, an alarm goes off. Gives our patients lots more freedom and lots more confidence in using insulin.
Wow, that's fantastic. That's amazing technology. We're almost out of time here. So it looks like people, if they have diabetes, they can do something about it.
Absolutely.
They can get to somebody like you, and you have some great devices that can protect them and have them live a long, healthy life and
Absolutely.
and keep them from cardiologists.
Well, this is a disease that now is much more livable. It's easier, and patients become educated, and the physicians and specialists will help them out, and they're not alone, and they can live a good, healthy, long life, and just takes a little bit of effort on their part.
Fantastic. Thanks so much for coming today. I learned a lot. I didn't know you had some of those devices. I appreciate it.
Lots of gadgets and more on the way.
Great. Thank you so much.
You're very welcome, Larry.
Fact or fiction? Red meat raises cholesterol.
Fiction. Studies have shown that people who eat lean red meat had no significant rise in their cholesterol when compared to those whose diet consisted of a lean white meat. Welcome back. We have a very special guest host today, Rena Santora.
It's great to be here, Larry.
Rena is my wife, and she's a practicing registered nurse here in Orange County for the past 30 years, and we're going to discuss organic food today.
Larry, organic food at the market is more expensive. Is it worth the price?
Well, this is it. It's more expensive because to be organic, you can't use pesticides and you can't use chemicals. And therefore, the yield of the crop per acre is less, so naturally, it's going to be more expensive. And whether it's worthwhile, that's what we have to determine.
Are they healthier?
There is a lot of debate about that. Some people think that the nutrients are higher, the antioxidants are higher in organically produced food. Some recent studies that came out said they are, but there's been contradictory studies. So really the jury is out. I think some people really believe in organic food, and they will pay any price for it. Certainly it's safer for the environment because you avoid pesticides and chemicals going into the groundwater. We don't really know, to be honest with you.
So are they really worth the price?
Well, if you believe organic is worth it, as a rule of thumb, if you can peel it, then you don't need to do organic because the chemicals reside on the outside. So if you can peel something like a organically grown potato, it's probably not worth paying the extra money. Lettuce, cabbage, celery, strawberries, those are probably worth going organic because you cannot get rid of the chemical residue on the outside. Apple is in between because you can peel it or eat it. When it comes to dairy products, if there are chemicals they tend to reside in the fat of the dairy product. So if you go low-fat or non-fat milk, it's probably not worth going organic. Same thing for low-fat yogurt. As far as fish goes, there's no known organically grown fish as far as we know, or criteria for that. And chicken and meat, we're really not sure whether it's worth it, to be honest with you. So as a rule of thumb, if you can peel it before you eat it, it's probably not worth going organic.
So if we can spend less on organics, let's do it.
That's a great idea, Rena. Thank you so much for joining us. Please email us your comments to healthmatters@chapman.edu. I'm Dr. Larry Santora, and remember, your health matters.
So when we're thinking about treating sleep apnea and snoring, the goals are to try to treat those areas that we talked about, obstruction. So sometimes what we'll do is we'll straighten that bone out in the middle of your nose and shrink the size of your nose for you to get more airflow. We'll sometimes shorten this palate with a variety of techniques, remove the tonsils, create less space so less of this tissue is collapsing around the area.